liver diseases. Let's first talk about jaundice, then I'm going to talk about liver function tests, and then I'll get into the diseases, because we're going to use in those terms so you can understand what's going on. All right, jaundice. We talked about this before, but we're going to go more into detail just because it's all about liver and gallbladder stuff. So jaundice, we also refer to it as icterus and also hyperbilirubinemia. Okay? It's much easier to just say jaundice. But all that's the same. It's not a disease, it's a sign. As much as vomiting is not a disease, anemia is not a disease. They're a sign of some other disease. Okay? So where does all this bilirubin come from? Okay, we've got to break down blood, red blood cells. Red blood cells only last for 120 days. So we need to break it down, and we're going to recycle things. So they'll last for 120 days, and we break it down. And what happens here, I found this nice little area here. So you have this hemoglobin that we need to break up into two things, globin and heme. All right? Globin is a protein that we can break down into amino acids. Well, amino acids we could use throughout all our cells. So that's an easy fix. So the protein turns into amino acids. That's all taken care of. But we have this to worry about, heme. The heme is broken down into two things. Iron, and the iron is going to go back into your bone marrow so that we can make more red blood cells. So we recycle the iron, okay? But we also have the thing that's going to hold the iron, the heme part of it, that's going to hold it. So that's what we call as bilirubin. Now, what happens here, the spleen is going to take this heme and break it up into iron and bilirubin. But this bilirubin is what we call unconjugated. It's also called indirect bilirubin. What this is insoluble bilirubin. This is not water soluble. So we got to somehow go from the spleen and bring this bilirubin to the liver, which is the liver needs to get it out of our body. But we've got to get it into the bloodstream. So what happens here is that this unconjugated bilirubin cannot get into the bloodstream unless it's attached to albumin. Albumin is going to make this unconjugated bilirubin water soluble. It's kind of like if I want to cross the Atlantic Ocean, I can't go into the Atlantic Ocean and underneath the water, I can't hold my breath like that. But if I go inside of a submarine, now I become water soluble. That's just what's happening here. This unconjugated bilirubin goes onto and gets attached to this albumin, which makes it soluble. Now it goes into the bloodstream. And the liver is going to make that water insoluble bilirubin into something that's water soluble. So it's going to what we call conjugate the bilirubin. Once the liver does that, then it becomes water soluble. So the liver cells will take the unconjugated bilirubin in the blood, make it conjugated, which is now water soluble. It's now going to go into the bile, into the intestines, and it goes out into your feces. Bilirubin has a yellow pigment to it. So that's what makes your stool a brown color, is that in order to make brown, you got to add some yellow to it. That's what makes it brown, is this bilirubin. There is some, it has to go through a few other steps, which I'm not going to go into, but it goes in a few other steps, and some of this bilirubin is also going to go to your kidney, and then it goes out your kidney also. And that's what makes your urine yellow, okay? So questions, this is what normally happens. Questions about that? Should be all old stuff from A&P too. Okay, so there's three groups of jaundice, okay? We can either say that jaundice is prehepatic. Prehepatic is that, now just, you're going to have to like think about this now. Prehepatic jaundice is bilirubin that's increased because of some reason before it hit the liver. Something went wrong. A good example of this is hemolytic diseases. What happens here is that normally what would happen is your red blood cells die, and let's say 100 red blood cells die, and your liver can take up the 100 red blood cells and can manage that. increase of red blood cell breakdown is astronomical. If the liver can, I'm just giving you numbers, if the liver can take 100 at a time, now hemolytic disease, the breakdown of red blood cells, is 10,000. That liver can only take 100. So now the spleen breaks them all down, and this bilirubin, which is conjugated or unconjugated, is it water soluble or water insoluble? Insoluble. So it's unconjugated bilirubin that's going to increase because your liver is overwhelmed with all that bilirubin. It can't do it. So in this case, this is prehepatic jaundice, is when you have an increase of unconjugated bilirubin. Does that make sense? Yeah? Okay. We also see that as physiologic jaundice of the newborn. When the baby comes out, the baby is trying to adjust to new foods and new things from from the inside the womb. So what's happening here is that the red blood cells are breaking down, and the liver is going to conjugate that. The problem is that a lot of times, this liver is not mature yet in a newborn. So if it normally takes 100 red blood cells, or 100 molecules of bilirubin, but now it's immature. It can only take 20. So therefore, you're going to increase the unconjugated bilirubin in a newborn. That's why we see a lot of newborns that are jaundiced. Most of the time, it's nothing to worry about. We've got to see the level of it. There's a certain number that we have to do further things, but most of the time, we can send them home. Okay? So does that make sense what prehepatic jaundice is? Okay. We could also have intrahepatic jaundice. This is jaundice that happens because of something's happening inside the liver. And a good example of this is hepatitis or cirrhosis. Something's happening there. Okay? Again, your unconjugated bilirubin is going to increase because the liver can't conjugate it. Does that make sense? Okay? And then we also have posthepatic jaundice. This is where the liver took in all the rightful amount of bilirubin, conjugated it, but now it's trying to get it out of the liver, but there's some kind of blockage. Maybe a gallstone or something. So in this case, what's going to increase is conjugated or unconjugated bilirubin. If it's posthepatic. Conjugated. Does that make sense? You following me? Like, it's not hard. If you understand the concept of this, it's not hard. Okay? So that's what's happening with that. So you should know prehepatic, intrahepatic, and posthepatic jaundice. Don't get confused, but although it's similar to, we're going to talk about portal hypertension. We talked about that last time too. But it's easy. We're breaking it up. All right? Do this on your own. The chart that I just gave you before was just this section here. I kind of cut it out for you. Okay? But here you have prehepatic, intrahepatic, and posthepatic, and you can see where the issues happen in terms of the liver, where the blood is, where the feces, and certain things where you have an increase of unconjugated versus conjugated and so forth. It kind of puts things in perspective. I like that chart very much. Okay? So jaundice. So here's manifestations of jaundice. What happens? We talked about some of this stuff, right? You get yellow sclera in the eyes. Remember, there's too much bilirubin that's leaving the bloodstream and it's going elsewhere and can go into the sclera of the eye. You go into your skin. That's why you appear to have yellow skin. The problem is when you have a lot of bilirubin that goes into the skin, it creates an intense itchiness. We call it pruritus, and that's what happens with that too. Your stool color changes, all right? If we have an increased unconjugated bilirubin, you're going to have darker and normal stools. Whereas if you have conjugated bilirubin increases, the stools tend to be very pale, okay? The urine color may appear darker, all right, if we have too much bilirubin, all right? And kernicterus. We talked about this before. Kernicterus, you see this in newborns. And this is why we get a little aggressive if the bilirubin level is very high in a newborn. If it's at a certain number, I forgot the numbers here, you won't have to worry about that. But if it gets too high, what we're worried about is the bilirubin can go into the brain and cause brain damage. And that's what we got to watch out for, okay? In a case like that, if it gets too high, they usually put eye patches or some kind of eye shade on the baby's eyes, and they put them under ultraviolet light. And I don't understand the mechanism of that. When they're under ultraviolet light, it kind of speeds up the elimination of the bilirubin. I'm not too sure how that works. Okay. All right, so we have liver function tests. All right, and part of that is enzymes. Okay, so we have a few different enzymes. We have enzymes that deal with the involvement of liver metabolic reactions. Now, the main ones here is the SAT and ALT, and you should know what those are. The presence of some of them could also be in the cells of the bile ducts. And I'll show you a picture so you can see what this is. We have GGT and alkaline phosphatase, we refer to as ALPHOS. As much as you've seen before with heart attacks, you've seen if there's damage to the heart muscle, it's going to release enzymes into the bloodstream. And when we see those enzymes in there, it tells you that there's myocardial injury. Same way here, that if the hepatocytes get injured for whatever reason, it's going to release enzymes. So that's the way you pop open a balloon. And AST and ALT are going to get released. Okay? If the bile ducts, let's say where the bile goes down, eventually it goes down where the gallbladder is, if that gets involved, then these numbers will go up. So if you have liver disease, AST and ALT will go up. And then if there's something wrong with an obstruction in the biliary tree, then you're going to see GGT and ALPHOS go up. Now, do keep in mind that if there's a blockage of the biliary tree, these will definitely go up. But if it's chronic, then these will go up too, because gallbladder disease can lead to liver disease, and vice versa. Okay? So just so you can visualize what's going on, this picture might make more sense. So here you have the hepatocytes, right, the liver cells. And inside the liver cells, you have AST and ALT. In the intrahepatic bile duct, so the bile duct going to the gallbladder, the lining of it will have cells that contain ALPHOS and GGT. So if there's some kind of blockage in the gallbladder, gallstone or whatever, then there's going to be a backflow of blood here, or backflow of bile here, and these will actually burst. And that's why the GGT and ALPHOS goes up. If there's something wrong with the liver disease itself, these will actually burst and release ALT and AST. So you should have a concept of that, okay? So those are liver function tests, at least the enzyme sources. But we could also do other liver function tests. For instance, like we just talked about, bilirubin, conjugated versus unconjugated. If you have an increase of liver disease, you're going to increase bilirubin. Okay? Albumin. Albumin is all made by the liver. So if the liver is diseased, like cirrhosis or hepatitis, then you're going to have a decrease of albumin. Okay? And all the things that attach to albumin are not going to be able to attach properly. Okay? You could also do coagulation tests. Remember, clotting factors are all made by the liver. So if your liver's diseased, you're not going to be able to clot blood properly because those clotting factors are not being made. So we test things, the prothrombin time and the partial thromboplastin time, the PT, PTT. Now these are times for the blood to coagulate. So if you have liver disease, then the time to coagulate and you're not making those clotting factors is going to expand. So you're going to increase the PT, PTT. Does that make sense? Okay? So the way I see this is that the liver, when I say these are liver function tests, LFTs, the enzymes are really not liver function tests. They just tell you if there's liver injury. These are really liver function tests because they're really testing the function of the liver. Does that make sense? Okay? But when we ask for a liver function test panel, we get the AST, ALT, GGT, ALPHOS, and all these over here to see what's going on. Okay? So you'll be checking those off and, drawing blood and stuff for LFTs. You should have an idea for those. All right, questions about that? All right, so now let's get into the diseases. All right, cirrhosis, big one here. Cirrhosis, most people think alcohol. I mean, that is a biggie for this, but it's not the only thing, okay? Cirrhosis is a widespread scarring and death of the liver cells, known as the hepatocytes, okay? It's progressive, it's irreversible, so once you have it, you could stop it, but you can't fix what was done, and it's incurable. They're going to need a liver transplant, okay? There's nothing else you can do with that. This is usually the end stage for many liver diseases, and it occurs when 80 or 90% of the liver is destroyed, okay? The liver is a very resilient organ as much as the kidneys are. It waits until about like 80% is gone before something really goes bad, all right? It can still function pretty well, okay? So what's the causes of it? Like I said, 2/3 of it is alcoholism, no doubt about that, okay? But that's only 2/3. The other third, well, is idiopathic. 25% of that is idiopathic. That's supposed to be cryptogenic. I got to fix the spelling on that. Cryptogenic cirrhosis. It's idiopathic. We just don't know the cause of it. But you're going to see later on, I think it's more of non-alcoholic fatty liver disease. We'll get into that one a little bit later, but I think that's what most of these are. You also get fatty liver disease, certain drugs, viral hepatitis. We'll get into hemochromatosis also. There's other causes too. So alcohol, yeah, that's the biggie, okay? All right, so what is this? What is happening here? Well, the liver, like I said, is a very remarkable organ. It's very resilient. It has wonderful, remarkable regenerative powers. In other words, if you need a liver transplant, all you need is someone's liver. All you need is half of the liver. When it goes in you, it will grow to a full size. It's very impressive the way the liver does this. Okay. So what happens here in cirrhosis? The hepatocytes start dying down and starts being replaced by fibrosis, scarring tissue. Okay. As soon as the hepatocytes die, it's going to the other remaining hepatocytes will multiply. They'll go through mitosis. The problem is the hepatocytes can't keep up with the amount of hepatocytes that are dying. Again, if there's supposed to be, let's say, I'm just giving you numbers, 100 liver cells or hepatocytes die, then 100 should be made. But now with cirrhosis, 1,000 are dying, but we can only make 100 at a time. They get overwhelmed. And a lot of these dying cells turn into fibrosis. So now most of the liver turns into this scarred mass. So now some of the cells are going to multiply, but has no place to go when they multiply. So they kind of go in these little swirls. So these swirl-like areas. They can't go out anywhere. So they kind of be more and more. And these swirls are what we call nodules. So cirrhosis is an area that has a lot of fibrosis or scarring and a lot of nodules. And eventually, the hepatocytes can't make any more, so then the cell just dies. It can't function anymore. It's trying to adapt to all these hepatocytes that die. But they can't go anywhere, so they make these little nodules. So the liver is going to enlarge first, okay, because it's trying to make more of these cells as it dies, but it can't keep up. So it enlarges, I don't know how long, maybe a week or a month or something like that. You don't usually see it, and then it shrinks. And it becomes this scarred mass, okay? So what happens is, because this scarred mass is happening, you're going to increase the intrahepatic pressure, okay? Which means you're going to destroy more of the hepatocytes. They have no place to go. They start getting damaged more. The liver becomes very tense and firm with all this scarred tissue. It can't expand. And the portal blood, the blood that goes to the liver, is going to be obstructed because it can't go through this scarred mass. You get portal hypertension that we talked about, and you get a backup of blood flow, and the blood is shunted to blood vessels of the GI and the skin. And when we get into portal hypertension, we'll go more about it. We talked about it briefly last time, my father-in-law, but I want to spend more time with it here. Okay? So there's two types of cirrhosis. All right, we can either have portal cirrhosis, and portal cirrhosis is it's the most common type, and this is where the scar tissue does disrupt the architecture of they're called lobules, liver lobules. They kind of destroy the architecture of the liver itself when you look at it microscopically. Okay, this is usually due to alcohol or viral hepatitis. But then we also have something where it's going to be biliary cirrhosis. This is rarer, and this is where the scar tissue does not, because it's now in the biliary area. It's not in the liver itself. So because of that, the outlines of the liver lobules are usually intact. They're not usually destroyed. You usually have a primary biliary cirrhosis that causes this, and that's an autoimmune disease that usually attacks the small bile ducts of the liver, but also gallstones and pancreatic cancer. Those are two types of cirrhosis. So signs and symptoms. Okay. Okay. So let me draw this picture. All right. It's kind of like what I did with you before, but since we're talking about this, so the hepatic portal system. You need to understand this because I think you're going to see this whole theme about pathophysiology is about backup. Right? If you understand the blood flow through the heart, it's all about backup of blood. When you deal with the hepatic portal vein, the system, it's all about backup of blood. So you need to know how it works normally to appreciate this. All right? So we have, I'll make it very simple for you guys. You have the spleen over here. Okay? Then you're going to have a vein that is going to go out this way. And you have another vein that goes here. And I'll name all these veins in a moment. And then you got this. Okay? So what we got here is okay. This is called splenic vein. Okay. This here is called this should be all reviewed for you guys from A&P2. That's the inferior mesenteric vein. I'll show you where all these are coming from. That'll make sense. This is the superior mesenteric vein. All right. Splenic vein. When the splenic vein and superior mesenteric vein come together, that's this one here, and that is your hepatic portal vein. The hepatic portal vein goes to the liver. You got another blood vessel that comes out here, and that is our hepatic vein. The hepatic vein is going to go to this gigantic vein that lies behind the liver, we all know and love, called the inferior vena cava. That will eventually go right to the heart, right? The superior mesenteric vein and inferior mesenteric vein are going to carry blood from the intestines. All right, I'm just doing this for review for you guys. Okay? So what I tell my students when I do this in A&P2, it looks like a horse with a big head. Right? If I do this thing like this, right? There's his head over here. Here's his neck. There's the front leg, the back leg, and there's the bushy tail. You see him? Oh, you would have loved me in A&P2. I do all these crazy things. The circle Willis looks like a spider. Inside your abdomen looks like a scarecrow. I do all that kind of stuff. But that's what's going on here. Okay? Now, the other thing I want to show you, let me take this eyes off. There's also the esophagus that's over here. And we have another blood vessel that will go from here up to and that's our esophageal vein. Okay? Does that make sense for you guys? If you understand that, then you'll understand all the side effects of what's happening with portal hypertension. Or most of them. Okay? So what happens here is, and we did this before, we have prehepatic, hepatic, and then we have posthepatic up here. All right? What's going to happen here is that if you have cirrhosis of the liver, all this blood, and the way the blood flow goes is this way. Right? It's all going to the liver. Does that make sense? The liver, after the liver detoxifies all the foods that you're eating, that's how the liver's going to work, then it's going to take all those nutrients and whatever they have to do, and they move it up into the hepatic veins, into the inferior vena cava, to the heart, and it circulates through it. Okay? It's called the hepatic portal system. Okay? So what happens is in cirrhosis, there's going to be a problem here. So that means the blood can't go in here, right? If this is like a highway that goes into the tunnel, which is the liver, and you got another highway that's up here. If there's some kind of motor vehicle accident that happens in the liver, all this blood can't get in there. So there's going to be a backup of blood. And blood is going to be going into the esophageal veins. They'll get dilated, and you'll end up having esophageal varices that we talked about. Okay? Do you understand that there'll be backup, and do you understand why your spleen will be large? Splenomegaly. See? Do you understand now? You would expect that this would also get large too. It doesn't, because it has a lot of place. It has like a long amount of. So what will happen is, instead of that, the blood, not the blood itself, but you're going to end up having a lot of, right, you're going to have fluid that's going to come out of here. As much as you're seeing fluid happen in the feet, right? And when it happens there, they get enlarged. There's swelling. Okay, does that make sense? All right. So that's what's happening. So you get ascites over there. So now, the way we break it down of cirrhosis symptoms, signs and symptoms, I broke it down into sections here. There's failure to break down estrogen and ammonia. The liver is supposed to break down estrogen. It's supposed to break down ammonia. But if your liver's shot, you're not going to be able to break down estrogen. Are you going to have an increased amount of estrogen or a decrease? Increase. If you're going to have, what's going to happen with ammonia? Is it going to be increase or decrease? Increase. So you're going to have symptoms of an excess amount of estrogen, excess amount of ammonia. Thinning of the hair, that's estrogen related. Coma. Ammonia will actually, if you have a lot of ammonia in your body, it's going to go to the brain, it's going to put you into a coma. Fetor hepaticus. It's kind of a weird thing. I don't know how it actually happens, but it means breath of death. And the only way I smelt it before, the only thing I could say it smells like, it's not like DKA. It's not like a fruity kind of smell, a fruity acetone kind of smell. It smells like, I know it sounds weird, but a sweet feces. It smells like feces, but it has like a sweet smell to it. I wish you guys could smell it. So you can see it. But it doesn't smell anything pleasant, believe me. But I could smell that, and I could have an idea of you got liver disease. That's what I mean. You could. So if you ever, yeah, it's got a very, yeah. I could go on a floor that has all, let's say, like cancer floors, and I could smell, I don't know, the chemotherapy or something. I could smell something there. All right. When you go on a floor, if you're about to punch out and someone says, oh, someone's got like cirrhosis, before you punch out, just go up there and just talk to him so you can get an idea what that smell is. I wish I could record smells so you can understand what that is. I can only record visual things or sound, but I can't record smells. That's something that I guess we should do one of these days. But But I want you to smell, well, you can scratch and sniff, but I don't think anyone will do that for this. Yeah, yeah. So anyway, that's what it is. You also get spider nevus. Now what happens with spider nevus, estrogen dilates things. We'll get into this especially when we get to pregnancy. But it dilates things. So think of this as an arterial, okay, and it's going up, and it leads to, let's say, capillaries that leads to your skin that's up here. So what I'm going to do is I'm going to take this and draw it this way, so that you're looking at on top of the skin. Does that make sense? All right. And what you've got here is normally your arterial sphincter is going to be like that, but when you have a lot of estrogen, it dilates. It gets bigger. And that allows more blood to go into the capillaries, which means there's more blood that's going into the veins, or venules. And what happens here is that they actually have the veins going out like this. It kind of looks like a spider. And I'll show you what that looks like, all right, when you look down on that. You also have gynecomastia. Gynecomastia in men, they build their breasts because there's a lot of estrogen. They start turning on the estrogen receptors on the breast, and now they have breasts. Okay? They have a decrease in pubic hair. They also have small testes too. Okay? So this is all related to an increased amount of estrogen and ammonia. Okay? If you can't make the proteins, then what's going to happen is, and you got to go back to oncotic pressure, if you're going to have less albumin in the bloodstream, then you're not going to be able to bring more blood, or I'm sorry, more water or more fluid into the bloodstream. It's going to go out of the bloodstream. Right? You got to go back to chapter 6 or whatever that was. Okay? When that does, you're going to see a lot more fluid leaving here and going into the peritoneum, causing ascites. Okay? And edema too. You also get purpura. Why? Because you're not making clotting factors. All right? You're going to start making a lot of, you're going to increase your bilirubin, right? That makes sense. All right? So you're going to get jaundice with that, pruritus. And you're going to get all of this happening, right? You're going to have portal hypertension, so your spleen is going to get enlarged. You're going to get ascites for all that same reason we talked about. And also this thing called caput medusae. What happens here is that you get varicosities happening in the walls of your abdomen. And there's one that usually is very distinctive. It's around the belly button, about the belly button, okay? And it gets dilated over there. And I'll show you what that looks like, the veins. All right? This was from your textbook. Kind of puts everything together. Again, I broke it down into those 4 sections over here. I think that makes it really easy. I don't want you to memorize this stuff. I want you to understand. Why would, you know, if I said to you, someone who's got cirrhosis, would you have hepatomegaly? Would you have splenomegaly? Does that make sense? Because in cirrhosis, you usually get smaller, right, the liver. But the spleen usually gets bigger. So you don't have to memorize if you understand the concept, okay? So these are certain things. Here's that spider nevus that I kind of showed you before, what I tried to show you. It looks like a spider that happens over there. You see it on the skin, okay? Over here is that caput medusae. You see over here around the belly button, you have those dilated varicosities that are happening, those vein varicosities that are happening around there. And then here's gynecomastia in a male, the breasts enlarge, okay, because of the high amount of estrogen. Okay. Ascites, that's what it would look like under with a CT scan. And then you can see ascites, how it gets so vascular, it gets really distended. You can look at that and say, I know what that is. You know, it has a distension where it's like it's pulling, it's being stretched out. You can see what that is. So that's ascites. Okay? So how do you diagnose the cirrhosis? It's clinical, but all those things, if you start seeing all those things that we just talked about, you could probably bet your money's dollars that it's going to be cirrhosis. But to be absolutely confident, you do a liver biopsy, okay? The treatment, is a liver transplant. There's nothing else. It's incurable unless you do that. Prognosis is very poor. If you don't get a liver transplant, usually about 90% of people will die from this. Okay?